We'll start right at 12:01. For those of you who have come to Georgia Memory Net Insights for quite some time, we have moved from a Zoom meeting to a Zoom webinar just to protect us against those horrible Zoom pirates that we saw a couple of months ago. And so you're in for a treat. Hang on, we'll start in just a second. Hey, thanks for joining us. We'll just wait to 12:01 just to give everybody a chance to navigate into the room. Hey, thanks for joining us for Georgia Memory Net Insights today. We're here with Dr. Kalisha Bonds-Johnson, and you're in for a treat. So hang in. We'll be starting in just one second.
Excuse me.
Hey, thanks so much for joining us today on Georgia Memory Net Insights. We're pleased to have Dr. Kalisha Bonds-Johnson, who is a PhD RN and nurse practitioner of mental health, and she's a practice partner, and she's the best. So I work with her in the Integrative Memory Care Clinic. She's an assistant professor and researcher with the Woodruff the School of Nursing here at Emory University, Nell Woodruff Hodgkin School of Nursing. I'm going to get that eventually. So we're so glad that you could join us. I'm going to turn it over to Dr. Bonds-Johnson. Appreciate this. This is a great topic. What to do when your first medication approach doesn't work, switching, adding, and augmenting. Back to you, Kalisha.
Thank you so much, Dr. Johnson. It is a delight to work with you as well, and I'm happy to be here. So he has given a wonderful introduction, and so we will jump right in so we can allow for time, a lot of time for questions. So this is all I don't know why that won't go away. Are y'all seeing that whole you share?
We're good. We're seeing your
Okay.
slides. You've advanced them one, and so you can go
Okay.
to the next one. That's just
You
giving
know the
folks some info about their credit.
typical accreditation statements,
Yep.
disclosure statements. I have nothing to disclose. I am not that popular in research yet, but I'm getting there. And then the objectives are to understand the common reasons why initial psychiatric or psychotropic medications may not work, differentiate between switching, adding, and augmenting strategies, explore the roles and risk of polypharmacy, because that always comes up in psychiatric medication management. And I just wanted to take some time to talk a little bit about that, and then learn evidence-based approaches to treatment adjustments. So again, when the first line treatment fails, it's typically one of three things. Like, one, there's absolutely no response. You've given it the appropriate amount of time and nothing is changing. Two, there's these intolerable side effects that the patient and the family cannot live with. Or there's a partial response. So, if we rate pain, but hypothetically speaking, if we were rating depression from 0 to 10, 0 being completely, absolutely, yeah, that's weird. I'm not doing it that way. So again, let's say you've been completely depressed, suicidal. They're not suicidal, but they're not necessarily themselves either. And so you're getting sort of this partial response where it's like, something might be happening, but it's not enough to then have them out of full, in full remission of whatever is going on with their psychiatric symptoms. So we're just going to jump right in with different poll questions. Some will come before I've discussed the information and some will come after. So, just curious about, what do you think we should assess? What should be assessed before changing a psychiatric medication? Is it the duration of the medication trial, medication adherence, the presence of psychosocial stressors, all of the above?
And so we've got people responding to the poll. Thanks of those of you who are responding right now. We've got 8 people who have responded, now 9. So thanks. We've got 20 participants, so keep going. And we're also open to seeing your questions in the Q&A submission. I'll be watching those later. I think we'll go ahead and end the poll with 14 respondents. And here you go. Here's your answers.
Perfect. So, as I hoped everyone would say, all of the above, because that is correct. We need to pay attention to lots of different things when we're assessing medications and determining next steps. So, before changing, confirm the diagnosis. Oftentimes, I work in a space around dementia, and so it is it's always interesting to me as though we forget that people maybe had other diagnoses before they were given this dementia diagnosis. So I have had the pleasure of supporting families of individuals who have had dementia, sorry, depression or depressive symptoms, anxiety, bipolar, even schizophrenia before they were then diagnosed with dementia. And so checking to see that we have the diagnosis right. Um, Evaluating medication adherence while we prescribe the medication. Are they actually taking the medication? Do we have a way to know that the medication that we're prescribing is being administered the way we anticipated it? And then consider the duration of the trial. Was it long enough? So, again, with our antidepressants, our SSRIs, our medications that help with anxiety, SSRIs, SNRIs, they're going to take longer. So, I usually tell people, you know, 2 weeks, we're trying to see if there's been any side effects, intolerable side effects that we don't want. But it usually takes more closer to 4 to 6 weeks and then about 8 weeks to see the most robust results when it comes to your SSRIs, SNRIs, medications for anxiety, depression. But we know our benzos work really quickly. Like you're expecting to see a response, sometimes within 30 minutes to an hour. With our antipsychotics, it varies, but typically, we have some like risperidone where you can see results within 3 days. You have others like aripiprazole or olanzapine, Zyprexa, where it takes about a week to start to see results. So again, knowing the medication you're prescribing and knowing that you've given it a proper amount of time before deciding that it's not working. And then looking for co-occurring conditions. So I mentioned earlier, oftentimes there are clients. I strictly focus on individuals living with dementia. I work in a primary care practice that focuses on that, but they have other conditions that they're also being managed or should be managed, and making sure that we're looking at how we are dealing with all of the symptoms that are being presented. Um, and then, of course, dementia in and of itself has lots of different, depending on the type of dementia they're diagnosed with, there are lots of different symptoms and side effects symptoms rather, that we can see. And so, wanting to make sure that the medications we're prescribing are addressing those symptoms. And then revisiting psychosocial stressors. Sometimes it's just that life is lifing, as I like to say. And so your medication is doing the best it can given where that person is in their current environmental life situation, things like that. And so just recognizing that sometimes that person could be on the right medication regimen, is just that life is just too much right now, and we need to figure out some other strategies, some non-farm strategies to help get them through the situation. Or maybe it's that we need to, again, consider a different medication combination. But again, don't rule out or don't overlook or underestimate the power of what is going on in someone's world. And then, of course, ruling out substance use. I will say this is something I have to be reminded of a lot. Often in my client population, we don't have as much substance abuse or substance use, and so I have to remind myself frequently to check in on that part. So if you are like me and one of those people that doesn't go there immediately, just making sure you have those checks in place and checks and balances in place to make sure that you are checking that, or have colleagues that are checking it, and then debriefing with them about it. So strategy one is switching. So the definition: replacing one medication with another in the same or a different class. When to switch. So no improvement after an adequate trial. There's severe side effects or patient preference. I will say with patient preference, if you're switching because of patient preference, make sure you have a way to note that somewhere, because if you're anything like me, once I've discontinued a medicine, I don't often go back and look at what was discontinued to say, oh, let's try that again. So again, if it really is for patient preference and it's not really that it didn't work and it they saw something on TV, they wanted to try it, or they've got a family member that's taking something, or a friend said something in a support group and they want to try it based on patient preference. Just make sure you keep a note of that, because again, you may have to go back to what you were considering would be first line, but instead with patient preference. And personally, I try to meet people where they are. I have discovered that if patient preference makes sense, I go with it, because oftentimes, especially with psychotropic medications, if you believe a medicine will work, that is starting things in the right direction. And I have found that when I try to overstep what patients and families want with no real like evidence behind it, oftentimes it fails. So I just give them what they want. They often tell me, that didn't work. What would you like to do? And then I'm able to, again, build rapport. I'm listening to them. I'm keeping their thoughts and preferences at the forefront, but also then being able to give them what I initially wanted to give, which sometimes works. There are occasions where patient preference works just as fine as something I wanted to do. And so an example of switching is switching from fluoxetine to sertraline. Typically in psychotropic medications with SSRIs, we do 2 SSRIs before we move to the SNRIs. I know sometimes, if you're looking at someone who has a lot of pain, you might be more inclined to do the duloxetine over the SSRIs, but typically kind of just basic standard psychotropic medication. If you're looking at anxiety, depression, you do the 2 SSRIs. Once those 2 have been failed, then you move on to SNRIs. So next, strategy 2 is adding or combination therapy. So you're adding another medication to the current regimen. We do this sometimes where there's a partial response to the first med, or if you're treating multiple symptom clusters, so like anxiety plus depression. The example here is adding, I always want to call it bupropion. I never say it right, but Wellbutrin to an SSRI. We often see this because sometimes SSRIs can cause apathy. So I'm not depressed, but I'm just not interested in stuff, and I'm just not quite myself. And so sometimes adding that bupropion to an SSRI can be enough to sort of brighten affect, get them feeling and doing things that they normally enjoyed if we're thinking about more depressive symptoms. And then poll question number 2. We haven't got to augmentation yet, but when is augmentation most appropriate in psychiatric medication management? It's kind of a pretest, I guess. We're giving it to you before we actually get to the discussion.
Okay, your
When the
poll is
patient-
your poll is open now, and so we're looking for folks to respond to the poll. And let's see. I don't see anyone having responded yet.
I mean, it's a guess. We haven't got there yet.
Kim, is it? Oh, there we go. All right.
When
So we're getting in
augmentation,
some answers here.
wonderful.
That's great. Oh,
So
and it's not 100%. I can tell you that. You're going to have something to talk about here.
wonderful.
A reminder to folks to just make sure that you can put in question and answers in the question and answer section. We also have the reaction button open to you. And so if you want to react to anything that's been said with a heart or a thumbs up or some other positive reinforcement, feel
Or
free
a
to do
thumbs
that.
down. I'm open to that too. I mean, I work in psych.
Okay, hold on. We're going to go ahead and end the poll. We've got 56% participating, and we're sharing results. And so there you
Nice.
go.
So when is augmentation most appropriate in psychiatric medication management? When the patient has had no response at all, when the patient cannot afford medication, when there is partial response to a medication and switching is not preferred, and when the diagnosis is unclear. So technically, I was leaning more towards answer C, but I do see A and B as, I can see why you went there. So let's dive in a little bit. Augmenting is enhancing the effect of the current medication with a second medication. So I always tell my clients it's like 1 + 1 = 3. So you're getting this synergistic, this added effect. When to augment? When there's a partial response and when switching isn't preferred. So let's say we've got someone that is doing okay. And the example here is like an antipsychotic. I know in our older adult population, we often are so very leery of antipsychotics, and I probably would not give an antipsychotic to augment unless I had a client who also had a diagnosis of like bipolar or schizophrenia. So at that point, most of the times what we're doing Again, I truly believe in using antipsychotics for individuals that are psychotic in our older adult population, but there are often older adults that are coming along with other diagnoses that are also then having a dementia diagnosis added on top of that. And so you've got a partial response to an antidepressant. Sometimes adding the antipsychotic is helpful, to just sort of give that 1 + 1 = 3. I do like aripiprazole for that, or quetiapine. Those are kind of the two that in my mind have a lot of, I call them mood properties, but they have a lot to do with anxiety, depressive symptoms. They work a lot with the mood. And are often not as good, in my opinion, when it comes to the psychosis part. And then when switching isn't preferred. So, in some cases, we can do, I lean towards bipolar because I think it's one of those situations where you have these highs and you have lows. And so you've got someone on a low dose antidepressant because you're trying to keep them from being depressed. And you also know that with bipolar, if you raise the antidepressant too high, you can cause them to be more manic. And so, in a case where maybe they've been okay at that low dose antidepressant, but now they're starting to have more irritability and more agitation and starting to present more of that mood instability, then adding a potential lamotrigine, Depakote, Abilify, quetiapine, adding a mood stabilizer, whether it's our typical mood stabilizers or an antipsychotic to that, is also sometimes a way to get a little more balance and benefit. And polypharmacy, I have to discuss it because it is one of those things that, I'm being completely honest, slightly annoys me. I know we have to describe it, right? The use of multiple medications for one or more conditions. And it's common in psych, which is, I think, why I'm annoyed slightly by often the negative comments that come around polypharmacy. But we don't have one med that helps with cognitive impairment. We don't have one med that helps with depression, anxiety, and mood instability. We don't have one med that treats all of those things plus psychosis. And so I definitely understand that when you're adding multiple medications, you do need to check for drug interactions. Whether you keep whatever app you prefer to look and check drug interactions, I highly recommend it. Um, or books, whatever you're using, just make sure you check drug interactions. Increase side effects, of course. So anytime you're adding multiple things to this concoction, you're going to increase side effects. There is the concern for poor adherence too, because if you make a medication regimen too complicated, you're taking 3 meds in the morning and 2 in the afternoon and 4 at bedtime, that is a lot harder than just saying I take one medicine at bedtime or I take 2 medicines in the morning. And then it is higher cost. You're needing more medications. That's more prescriptions. It's going to cost more. But the caveat, I think, is it can be appropriate if carefully managed and monitored. And that is the lane that I like to stay in. That I do understand that we are prescribing multiple medications, but I am doing it in a thoughtful, appropriate way and managing and monitoring the clients to make sure that I know why I'm prescribing each medication, for what purpose I'm prescribing each medication. And again, we're looking at these principles of safe polypharmacy. So I'm using the lowest effective dose. We often do that anyway in older adults, is that we're using that lowest effective dose. I'm avoiding mechanistic duplications. So one thing I despise is a strong word. One thing I highly dislike is when people are on like 2 antipsychotics. Like, what is the reason for them to be on 2 antipsychotics unless there is a previous history of like bipolar or schizophrenia? Most of our older adult clients do not need 2 antipsychotics. It's a little messy and increases the risk of metabolic syndrome and all the other concerns. Like, why would we do it? And so really thinking about which one of these is working better, how do we potentially increase and maximize that before adding something else? And then of course monitoring our interactions with the CYP enzymes, QT prolongation, regularly reviewing the need for each medication. And so often I inherit clients, and I do this even with my own clients, where I'm looking at all of their psychiatric medications, all of their psychotropic medications, and trying to determine, okay, this is for this, and this is for this, and this is for this. You know, we've got this for anxiety, and this is for depression, this is for mood instability. Okay, why do we need this? And so, really trying to clean up the med list. I will say, when I first see new clients, I often don't make major changes because most of the time people are stable or barely stable. And so pulling a bunch of things away, making a bunch of changes is often not recommended unless, like I said, where you're on the two antipsychotics and there is no justifiable reason to be on two. That I will change immediately. But most of the time, again, we're reviewing medications. I'll even ask the families, the person living with dementia or MCI or the older adult, like, do you know why you're taking this medicine and that medicine, to get an idea of what the previous provider, clinician, prescriber was thinking, if I can't quite figure it out. And I'll often tell them at times, like, I'm not quite sure why this medication was prescribed, but you seem to be stable. Let's see if you need it. We can continue to monitor, and we may be able to pull a couple medications away if we don't think so. And then, of course, using evidence-based combinations when possible. So we do know there's been some work done on medications that tend to work better in our older populations or people living with dementia. And so leaning in to that information whenever possible, if and when we have to do polypharmacy.
Kalisha, I
Yep.
was at a polypharmacy lecture. Go back one slide just for a second. We'll hide that poll for just 1 second. I was at a polypharmacy lecture over this weekend, and the lecturer used the term rational use of multiple medications as opposed to the dangerous polypharmacy prescription cascade. Maybe that's a term that you would like as well.
I
Rational use of multiple
love
medications.
it
Okay.
because we don't have one medicine that does all of these things. And so when I worked in long-term care facilities, the pharmacist would send us these nasty grams, as I called them, for all of the things I needed to. And I'm like, I don't have one medicine that does all of these things. But I do love that. I'm going to actually have you tell me that again so I can write it down and use
That
it
sounds
moving
good.
forward.
We have your
Um,
first question in the question and answer,
oh,
and
perfect.
it's a good time to ask this question, and it's about augmenting. And so it's from Dr. Birju Patel. Hey, Birju, do you have experience with Vraylar? And that's the brand name. It's cariprazine instead of bupropion as an add-on. Any thoughts about efficacy of this agent?
I have not. Oh, um,
So So
go
we'll
ahead.
look for further comments from Birju about his familiarity with this medication and some thoughts. We welcome more discussion
Yeah.
about that later.
I know I'm
Um,
really interested. I might have to follow up an email
yeah,
afterwards.
that sounds great.
Um,
I always one of my professors always taught me never be the first to use a new medication. If it happens to be a new medication, you wait until about a year until all the post-marketing data. But we'll look for something more from Birju in the question and answers. And go
yeah,
ahead,
no.
let's launch the second quiz, please, or the next quiz, please.
Yes, the last poll. Which of the following is a potential risk of polypharmacy? So this one happened after the fact, y'all. See, I don't always give you pretest. Lower treatment costs, increased risk of drug interactions, simplified treatment regimen, or improved adherence.
We've got some agreement here. So here it is.
Wonderful. Wonderful. And I'm reaching for a book while I'm doing this. Okay.
I'll
Let's
let you look up something in a book just for a second and I'll pose another question for you. And that's when you start somebody on a medication, at least when I start somebody on a medication, I'll often find out when I talk to them 6 weeks later that they stopped the medication at week 1. And so do you have like a quick pointer for us to how to not have what happens
Yeah.
to me happen to you?
So typically, so that happened to me a lot at first, especially because SSRIs, I think a lot of the antipsychotic or psychotropic medications have that GI upset. And so people will stop a medicine because they're like, no, I don't need to go to the bathroom anymore. I don't want this discomfort, this nausea, vomiting, or whatever. So what I typically do with all the medications I prescribe is I start them at half strength. Also, because we're working with older adults, and sometimes they surprise me that half strength is just as effective as the whole dose. So again, If I'm prescribing fluoxetine, the typical starting dose I think is 20, but if I'm not mistaken, they have a 10 milligram. And so, or if I'm starting sertraline, the typical starting dose is often 50 milligrams. I'll start at 25 milligrams. And I'll have them do that for like a week or two. And I usually tell them, like I said earlier, for the first 2 weeks, I'm just trying to determine if there's any side effects. And so I'm going to go in a little lower than normal because sometimes that can trick your body into thinking that you've been taking this medicine and you won't see as many side effects. And when I say I'm following up, it's usually that I'm sending a message to our wonderful nursing staff that we have to say, do you mind following up with this patient in 2 weeks, either in the patient portal or by phone call to see how they're responding to said medication? And usually I hear that they're tolerating it pretty well. I'm not expecting to see any changes, especially with an antidepressant, on mood or anxiety. I'm not expecting with an SSRI, SNRI, I'm not expecting to see changes. Sometimes they'll surprise me and say they feel a little better, but typically not. Typically it's just that you're checking for side effects. And then I have nursing. I usually try to see my clients every month after I've made a medication change, but I don't have the extensive caseload that most of you all probably have. So if you can't follow up in a month, then it's nice to have nursing or just some sort of a touch point in a month to see how they're doing. Because again, the other thing, similar to what Dr. Johnson was saying, is that when people don't feel like things are progressing, they will stop the medication because they're like, it's not working. And so I often try to give them again, first 2 weeks, I'm checking for side effects. 4 to 6 weeks, I'm trying to see if you're feeling anything. But again, it might take actually 2 months, 8 weeks or so before we know the most things. So just let me know if you feel nothing, you feel worse, or you feel better.
I really like that, Dr. Bonds Johnson. I'll give you a time check here. We're at 12:25, and so we'll let you go on the home stretch.
Yes, almost done. So patient-centered considerations always share decision making. And in my mind, that's not just between the clinician and the family, it's also between the patient and the family, often in our cases. And then discussing your risk benefits expectations. Of course, we try to do that. I often try to tell clients what I expect them to see. You should see more of this, less of that, so they actually know what to look for, especially family members. Sometimes they don't quite know what to look for in a person living with dementia or an older adult that they're supporting. And so consider patient values, lifestyle, previous experiences. Often in with psychiatric medications, if they have a family member with the same diagnosis and they were prescribed a medication, it often will work in families. And so sometimes knowing what, my mom took this or my sister took this and it was helpful or beneficial, it also sort of, I have noticed, adds buy-in, because a lot of times the family members are like, oh, they're listening to me. They're comfortable enough with the medication because someone in their family has taken it. And then, of course, reassessing regularly for effectiveness and tolerability. And I think monitoring and follow up. So, of course, using measurement based care, we often use the PHQ-2 where I work, schedule frequent follow ups after any med change, monitor labs, and then document the rationale for each strategy, especially if you decide to discontinue a medicine. Because, again, we're not often going to the previously prescribed meds to say, oh, let's try that again. So keeping some sort of a record or a reason for why the medication was stopped, especially if it was stopped and it wasn't because of a negative thing. Like maybe it was stopped because like the patient tried it for a week and then decided they didn't need it, or whatever the case may be. If they didn't have a proper trial on it, being able to keep up with that is important because that might be the right medicine for them. I also do like the gene site testing and the different swabs in the mouth testing to sort of give you a little more information when it comes to psychotropic medication. It often helps with just kind of knowing how they will how their body will respond to the medication. So it often helps you with knowing how much to increase the medication. So if you've got someone that's a rapid metabolizer and they're burning through the medication really quickly, then it's nice to know that you can use higher doses. If you got someone that's an ultra slow metabolizer and so they're holding on to that medication, it's nice to know so you can prescribe a little less. And I think that's, again, key takeaways. If the first approach fails, don't panic, reassess, and plan. Switch if no response or bad side effects, and make a good note of that. Add for partial response or multi symptom targets, and augment when a boost is needed. Polypharmacy can help, but it must be used judiciously. And I think that's all I have.
Super, super helpful. Thanks to Emma and Kim for getting us all set up on the webinar. And there's some more information about how you claim credit for CME. And so really, really appreciate that. We're gonna send you. Is there another slide for feedback on today's session?
Oh,
Oh, that's okay. And
that's all
so
right.
we'll send you, if you registered, which is the only way we got in the room, we'll send you out a survey about this. And so thanks so much. And Dr. Patel wrote that cariprazine is an atypical antipsychotic that's being marketed heavily now for depression, mania, and bipolar disorder in terms of an add-on. And so we'll see if we can find out more about that. My earlier suggestion still holds. If you're the first one to use a medication, then that's probably pretty bad. Wait for a year for that post-marketing surveillance to come out. But it's always good to be paying attention to things that are coming on the market. So Dr.
Yes.
Bones-Johnson, I had another question for you, and that's on my board review, there's a wrong answer when you add an antidepressant to somebody with bipolar disease for the reason that you just said, is that sometimes that can spark mania. What is it that you do to make sure that you're dealing with depression and not bipolar disorder?
You know, this is interesting because we actually just had a client a couple weeks ago. So I inherited this client. Um, daughter caring for her mom has a diagnosis of dementia, but was starting to get really, really agitated. And so I'm like, well, they're on Zoloft at like 50 milligrams. Why don't we go up on the Zoloft? It could be anxiety related, and with Zoloft or sertraline, above 100 milligrams tends to be better for anxiety. And so the daughter said, well, we've tried that before, but she gets even more agitated and really, really out of her. She doesn't do well. And I thought, okay. And so I kind of sat with it. And then she sent me a private portal message and was like, I just wanted to share my sister has bipolar disorder. And I'm wondering if that might be something that mom has as well. And so she gave me a few more rundowns of different meds that didn't act how we would expect the meds to act. And so I'm not going to add bipolar to her chart, but I am going to think about it carefully. And so when you are giving an antidepressant, especially in our older adult population, we're not starting really high. You're going to give, the lower dose, half the normal dose, the starting dose. And as you start to go up, what you typically see is that they become more irritable, more agitated. They're mean, they're not kind. It isn't doing what you would expect it to do. And so there are ways to augment that, in that you use either your mood stabilizers or your antipsychotics. And so, again, I think this goes back to the original question, where if there is an antipsychotic, one that your clients can afford, because oftentimes I go with what I know. So I haven't been really big on prescribing Rexulti because, again, I don't have a lot of personal data on how it will operate and work to be able to share with my families. But I would assume this medication, given the FDA approvals, would be one potentially that could have that same effect. So you're trying to make sure you're balancing keeping them from being depressed, but also keeping them from being manic. And I will say, with your mood stabilizer, so your lamotrigine and your Depakote, they are not as strong at being able to manage the mania potentially associated with your antidepressant. So definitely keeping the antidepressant at half strength or the starting dose whenever possible. And then like your aripiprazole, your quetiapine, and then this other medication that was mentioned that just went out of my head. With those, typically your antipsychotics are stronger. So aripiprazole is one of my favorites, especially when I had people like for my 40-year-olds, 50-year-olds who want to be a little bit manic, who know they're bipolar. That's what they're dealing with. They like being a little bit manic, a little bit above baseline, a little hypomanic, but they know that when they're in full mania, they can get nothing done. And so aripiprazole is one of those that sort of allows them to be a little manic, a little hypomanic, and still be able to function. Because otherwise, with your bipolar patients, they just completely stop taking medicines because they don't want to feel the way often these medications make them feel. I don't know if I answered your question, but
You did great. Dr. Bones-Johnson, thanks for a great session today.
yeah.
It's always good to talk to a prescriber who's been through these and to
Mhm.
ask her to just sort of say, what's in your head? How are you doing this? I really love this setting the expectation for your patients. Like for the first 2 weeks, we're just going to make sure that you don't have a lot of side effects. We'll get you to the right dose at about 4 weeks. We want you to continue to take it. And it may take about 8 weeks until you feel well and about 12 weeks until we figure out how this medicine is really going to work. So that was extremely helpful for me. Well, thanks everybody for joining us. We'll let you sign off. And thanks again. I know we're going to reach out to Dr. Patel about that new medication, see if we can offer it. We'll